Is my mind going, doctor? Are you telling me I have dementia? The patient stares across the desk at you, hands trembling slightly, waiting for an answer to a question no one ever wants to ask. If you are an international medical graduate preparing for GMC registration, passing OET Speaking for Doctors means navigating these emotionally intense moments with calm, senior authority. Under tight exam pressure, many IMG doctors panic when a patient reacts with sudden distress. They default to junior habits, reciting raw test scores or dense medical terms to keep the conversation moving. However, delivering a severe diagnosis without an emotional buffer triggers instant patient alarm, causing severe consultation timeline drift. In this masterclass, we are breaking down how to manage difficult diagnosis conversations cleanly. I am going to show you a subtle four-word anchoring phrase that settles patient distress instantly, protecting your management runway while securing your marks across the board. Let's look at how official assessors evaluate this exact moment on their scorecard during an OET consultation roleplay. When you deliver a life-altering diagnosis, examiners are not just listening to your medical accuracy, they are evaluating your performance under relationship building criteria and providing structure criteria. When a doctor drops unframed clinical findings onto an unprepared patient, assessors record an immediate deduction under relationship building for failing to show empathy and causing avoidable distress. Simultaneously, the patient's resulting emotional panic forces you to spend the next 2 minutes reassuring them out of structure. That timeline leak drains your management runway, leaving you with insufficient time to explain support steps or complete safety netting. The scoring deduction is not a reflection of your English fluency. It is a direct consequence of a consultation structural leak under pressure. To break difficult news with complete clinical authority while keeping your consultation perfectly on track, deploy a 3-step method called the Compassionate Anchoring Protocol. Step 1. The empathetic buffer. Before speaking any diagnostic label, acknowledge the emotional weight of the consultation and prepare the patient for serious news. This softens the psychological impact and signals that you are in control. Step 2. The grounded reality anchor. State the clinical picture using clear, non-jargon language, immediately anchored by a steady 4-word boundary phrase. We take this step by step. This validates their concern without letting emotional panic derail the consultation. Step 3. The immediate action horizon. Shift the conversation away from catastrophic long-term fears and focus directly on immediate, manageable support options. Landing this protocol relies heavily on your vocal architecture. You must use unhurried speech pacing, sympathetic warmth, and a firm downward pitch inflection on your anchor phrase to project calm, consultant composure. First, listen to Dr. A make the common mistake of leading with raw test scores and medical jargon without an emotional buffer. Dr. A. Well, Mr. Harrison, your cognitive assessment score was 72 out of 100, which indicates early-stage vascular dementia caused by microvascular changes in the brain. We need to organize a CT scan and consider starting acetylcholinesterase inhibitors. Patient. Vascular dementia? Are you saying I am losing my mind completely, doctor? Will I have to go into a care home? Dr. A. Well, no, please try not to panic, Mr. Harrison. The score is just a screening marker. We still need to run further tests and imaging before we know anything for certain. Dr. A dropped raw diagnostic numbers and textbook terminology directly onto the patient, triggering severe health anxiety. The patient panicked, forcing Dr. A into a defensive loop that destroyed their remaining consultation structure. Now, listen how Dr. B handles this exact same moment using the compassionate anchoring protocol. Dr. B. I can see this news feels overwhelming, Mr. Harrison, and it is entirely natural to feel anxious right now. What the assessment shows is that there are mild changes in how your brain processes complex information. consistent with early-stage vascular dementia. We take this step by step. Our priority today is not about losing your independence. It is about putting proper support in place so you stay safe, comfortable, and well supported at home. Would it be helpful if we discussed what those first small steps look like? Patient. Yes. Thank you, doctor. That makes sense. What do we do first? Let's compare Dr. A and Dr. B directly against the examiner scorecard. Dr. A opened with a raw score, 72 out of 100, and loaded the sentence with clinical terminology like microvascular changes. This forced the patient into an immediate panic response, resulting in rubric deductions under both relationship building and information giving. Dr. B, by contrast, led with an empathetic buffer before introducing the diagnosis. Notice the structural pivot. Dr. B anchored the clinical explanation with the steady phrase, "We take this step by step," delivered with a decelerated tempo and a calm downward pitch. This phrasing choice instantly settled the patient's anxiety curve. Instead of defending a clinical term, Dr. B satisfied the incorporating patient perspective criteria in a single sentence, protecting the consultation timeline and transitioning smoothly into collaborative management. This framework works universally across the entire OET Medicine syllabus. Consider how seamlessly it adapts when communicating an urgent dermatology biopsy result in an outpatient clinic. Patient: does this mole test mean I have skin cancer, doctor? Dr. B: I know waiting for biopsy results is deeply nerve-wracking, Mrs. Bennett. The tissue sample did show dysplastic cell changes. We take this step by step. Our priority today is simply organizing a minor surgical excision, so we treat this early and clear it completely. Mastering difficult conversations in OET consultations is never about memorizing long scripts. It relies on clear structural framing, empathic anchors, and calm vocal composure. Which specific clinical diagnosis causes you the most anxiety when breaking difficult news during your practice sessions? Drop your scenario in the comments below, and I will help you refine your clinical phrasing. To see how this early dementia strategy aligns directly with official scoring criteria, like providing structure and relationship building, download the complete PDF criteria map from the Expansion Vault. Access is completely free via the link in the description below, and let me know where your consultation structure leaks most on test day.